சரி உங்க வீடியோஸ் போட்டோ
வீடியோ ஆன் பண்ணிருக்காங்களா? வீடியோ இன்கமிங் வீடியோ ஆஃப் பண்ணுங்க.
அவர் நம்மது
Good morning, everyone. Today we'll talk about fistula in ano and anorectal abscess. The reason why we club these two topics is these two things go hand in hand. Most often they'll be coexisting. Okay. To understand this, we'll have to refresh our anatomy from last class. Okay. So first of all, we'll start with anatomy. Then we'll talk about anorectal abscesses first, and then we'll deal with fistula in ano. So as you all remember, the anal canal is 4 centimeter in length, extending from puborectalis, part of the levator ani muscle, to anal verge. The upper half of the anal canal is made up of vertical ridges called anal columns, and at the lower end of these anal columns, there is semicircular flaps called anal valves, which represent the dentate line or pectinate line. This we have discussed in the last class. Okay. So what happens is at this dentate line, when precisely at these anal valves, there are certain glands called anal glands. Okay. And there are ducts. Most of the anal glands are present in between the internal and external sphincter. Okay. So roughly about 2/3 are present in the space between internal and external sphincter, that is called as intersphincteric space. Okay, these anal glands, they produce mucus, and those mucus empty into the anal canal, okay, to facilitate the easy passage of bowel movement or stools. So the ducts which empty these mucus into the anal canal are found along the dentate line or pectinate line. Okay, so this is the anatomy that you are supposed to know for today's class. The previous class we have discussed about the variations in the blood circulation, venous drainage, lymphatics, and nerve supply, that we have discussed. But for today's class, you need to know about the anal glands precisely, where they are emptying their mucus. Okay. So it's also worth noting the sphincters anatomy. So we've got internal sphincters and external sphincters. External sphincter again has 3 parts: deep part, superficial part, and subcutaneous part. So external sphincter is the one which is under voluntary control. Okay. And then we got internal sphincter, which is nothing but downward extension of circular muscles of rectum, okay, which is under the autonomic nervous system control. Okay, so now we'll start with the topic, that is anorectal abscess. Okay, so anorectal abscess is mainly because of the infection of these glands. So 95% of the anorectal abscess are due to infection of anal glands in relationship to crypts. Hence it is called as cryptoglandular disease, because these glands are found in the crypts along the dentate line called crypt of Morgagni. So these represent 95% of the anorectal abscess. Okay, so most commonest organism is E. coli, followed by Staphylococcus, Streptococcus, bacteroides, and Proteus. It is most commonly seen in diabetics and other immunosuppressed patients. Okay, so upon infection of the gland, the pus travels through the path of least resistance. Okay, if it spreads caudally, okay, it ends up becoming perianal abscess. If it extends laterally across the external sphincter, it enters the esophageal fossa, forming esophageal abscess. Okay, and rarely superiorly it extends above the levator ani. Puborectalis is nothing but a part of levator ani. So if it extends beyond that superiorly, it becomes supralevator intramuscular or pararectal abscess. Okay, depending upon where it ends up accumulating, we have different types of abscesses. The source will be the same common abscess, that is infection of anal gland. That will be the source. Depending upon where it ends up accumulating, we have got different types of abscesses. Okay, so now different types of spaces and anorectal abscesses. The first one is pelvirectal abscess. Can you see the number one here? Yeah, it is above the one I am pointing is puborectalis. So above the puborectalis, it becomes pelvirectal or supralevator abscess. Okay. Number two is, see, this is internal sphincter, which is downward extension of circular muscles of the rectum. So this becomes your internal sphincter. Okay. So it is it is between mucosa and internal sphincters. So it becomes submucosal abscess. Okay. Then number three is here. It is lateral to external sphincter. So what did we discuss here? Anything that travels lateral to external sphincter becomes esophageal abscess. So this is esophageal fossa, which is bounded by your obturator internus here, levator ani, external sphincters. So this becomes your esophageal fossa. So this is esophageal abscess. Number 4 and number 5 are marginal abscess and perineal abscess. It is the same if it is found at the anal verge. Okay, if the covering is part of mucosa and the skin, that is anal verge, it becomes marginal abscess. The same abscess, if it is little bit distal, little bit lateral, it becomes perianal abscess. Okay, and finally we have number 6. Number 6 is here between internal sphincter and external sphincter. So this becomes your intersphincteric abscess. So these are the different spaces and corresponding abscesses. Okay, again I want to repeat, the source of the infection is same no matter what we are talking about. It is infection of anal gland. It is only where the abscess ends up being collected. We have different types of abscesses. So other causes other than cryptoglandular disease, there are other causes of abscesses. One is injury to anal rectum, cutaneous infections such as boil. It can be folliculitis of the hair follicles seen in the perianal region. Okay, it can be bloodborne infection. It can be perianal hematoma or post-anorectal surgeries or Crohn's or sometimes even tuberculosis. Okay. Okay. Then we have differential diagnosis of anorectal abscess. Differential diagnosis are periurethral abscess, Bartholin abscess, and tubercular abscess. Bartholin abscess is the abscess due to infection of Bartholin glands that are seen around vagina. Okay, so that can also be a differential diagnosis. Now coming to each and every abscess in particular, first we'll talk about perianal abscess because that is the most commonest abscess, accounting for 60% of the cases. Okay, so this usually results due to suppuration of anal gland or suppuration of thrombosed external bile or any infected perianal condition. It lies in the region of subcutaneous portion of external sphincter. The clinical features are severe pain in the perianal region with difficulty to sit. There will be tender, smooth, soft swelling in the region, perianal region. That is accumulation of abscess. So treatment will be sitz bath, antibiotic, analgesics, local application of anesthetic agent and laxatives. These are all, of course, supportive treatment. The definitive treatment for abscess anywhere in the body for that matter will be drainage. Incision and drainage is the main and the only definitive treatment for abscess. So you have to perform drainage procedure under general anesthesia or spinal anesthesia or something called saddle block. So next come to rectal abscess. Again, rectal abscess, I told you it is because of the lateral extension of the abscess. So it has to traverse through the external sphincter, enter into the rectal fossa. Rectal fossa, again the boundaries are laterally it is obturator internus. Okay, and then we got levator ani external sphincter medially. Then we have got sacrotuberous ligament and gluteus maximus posteriorly, and below we have skin. So commonly it is due to lateral extension of intersphincteric abscess through external sphincter, but often it can be blood-borne or lymphatic-borne also. Okay. Now, one particular importance is it is rich in fat. This area is rich in fat, and this fatty tissue is having less vascularity. It is rather less vascular, hence it is more prone for infection. Okay. So the fossa communicates with the opposite fossa through post-sphincteric space, and so horseshoe-like abscess can occur. Okay, it presents with tender, indurated, brawny swelling in the skin over the rectal fossa with high fever. See, this high fever is seen in any abscess for that matter, no matter where you see. If there is an abscess, you will have fever with chills and rigor. One exception is your tubercular abscess, which causes cold abscess, which does not show any signs of inflammation. That is the only exception. Okay, the swelling is not well localized, and fluctuation is absent in rectal abscess because it is deep seated. Something which is deep seated, you cannot expect any fluctuation test to be positive. So treatment is again, you have to position the patient in lithotomy position, and then you have to give cruciate incision. Can you see here? This is cruciate incision. Okay, and a portion of the skin is excised. You have to connect these points all across and leaving behind a rhomboidal shaped defect at the end of the procedure. The purpose of doing this is we don't want skin and subcutaneous tissue to close earlier than the cavity itself. Suppose that happens, then there is cavity left behind, and again there will be accumulation of debris and abscess into that cavity. Again there will be new opening somewhere else, or the same opening there will be discharge of the collected abscess. So this leads to recurrence. Hence we have to excise bit more of skin and subcutaneous tissue, and we expect it to heal later, as later as possible. Okay, next we have got submucosal abscess. This accounts for 5% of the cases. Okay, it occurs above the dentate line, which can be drained through sinus forceps or through proctoscope. Okay, so this is deep into the anal canal, and it is submucosal, that is between the mucosa and internal sphincter. Hence the only way to detect is through digital rectal examination, and while performing digital rectal examination you can expect tenderness. Okay, and smooth swelling is noted in the lower rectum and anal canal. It may be missed clinically as there are no obvious signs externally. Treatment is again proper antibiotics, incision and drainage under general anesthesia. Okay. Now we talk about pelvirectal abscess. Pelvirectal abscess are the abscess which are formed above the levator ani, that is puborectalis. So it is situated between the upper surface of the levator ani and pelvic peritoneum. Okay, it is most common like a pelvic abscess occurs secondary to appendicitis, salpingitis, diverticulitis, or even Crohn's disease. Okay, so if the infected anal glands end up, ascending upwards, then also you can expect pelvirectal abscesses, or it can be due to downward extension of the intraperitoneal abscesses. These are the intraperitoneal abscesses: appendicitis leading to appendicular abscess, salpingitis, diverticulitis, Crohn's disease. These are the intraperitoneal abscesses which trickles down into the pelvis, okay, the pelvic part of the peritoneum, and then enters the pelvirectal space, that is supralevator space. This will be your descending infection. Ascending infection will be from your infection of anal glands. So if they end up in that space, it becomes pelvirectal abscess. Again, we have to do ultrasonography of abdomen to rule out the appendicitis, salpingitis, other intra-abdominal causes. Thorough investigation should be done for Crohn's disease and other conditions. Again, treatment will be incision and drainage followed by appropriate antibiotics. Okay. So the problems with anorectal abscess is the recurrence. The most commonest problem is the recurrence. The second commonest will be fistula formation. Okay. So the fistula and anorectal abscess go hand in hand. Hence, we are dealing both the topics in today's class, because both are nothing but manifestations of cryptoglandular diseases. There is a larger entity called cryptoglandular diseases. Abscesses will be your acute manifestation of the cryptoglandular disease. Fistula will be chronic manifestation of cryptoglandular diseases. Okay, coming to fistula in ano now. Again, by definition, what is fistula? Fistula is connection between any two epithelial surfaces. Okay, you take any example for that matter. Tracheoesophageal fistula, connection between trachea, which is lined by a epithelium, esophagus, again lined by epithelium. So it is an abnormal connection between two epithelial surfaces. Okay. One more example, common example is enterocutaneous fistula, where the connection is between the mucosa of the gut to external, that is skin, that is also lined by an epithelium. So these are the examples. So fistula also qualifies, fistula in anal is also a type of fistula because it is connecting anal canal to external skin. Okay, so it is a tract lined by granulation tissue which connects perianal skin superficially to anal canal or anorectum or rectum, any of these three. Okay, it usually occurs in a pre-existing anorectal abscess which bursts spontaneously. Okay, hence we are dealing both together. So fistula in ano can be cryptoglandular, again cryptoglandular in origin, which is seen in about 90% of the cases, and there are non-cryptoglandular diseases which accounts for other 10% of the cases. So the other causes are tuberculosis, carcinoma, Crohn's disease, ulcerative colitis, lymphogranuloma venereum, hidradenitis suppurativa, and then we have other causes, just trauma or other things. Then classification, it is basically classified into low level fistula and high level fistula. These are the broad classification. Okay, high level and low level. The cutoff point is your puborectalis or anal ring. Anything above puborectalis or anything above anorectal junction is your high level fistula. Below that will be your low level fistula. Okay, there is one more classification called Parse classification. Parse classification, it talks about the course of the fistula. Okay, the path of the fistula. Okay, the commonest is your intersphincteric, that is up to 70% of the cases will be intersphincteric. The path will be between internal and external sphincter. Now we have got something called as transsphincteric, which traverses through both internal and external sphincter, that is transsphincteric. And we have got third one, which is supralevator or suprasphincteric. And finally, we have extrasphincteric type. So this is based on the path it takes. Okay. So here is intersphincteric. Okay. So here in the blue color, you can see the anal gland which is present in the intersphincteric space, but its duct is ending in the anal canal, precisely at the dentate line. So this is the example of a typical anal gland that you see. So coming to the red line here, the red path which is shown, the infection of this gland, okay, it has to traverse through internal sphincter. Internal sphincter has to be traversed, and then the path takes the internal sphincteric space. So this becomes your intersphincteric fistula. Then we have transsphincteric fistula, where both internal sphincter and external sphincter are traversed, and the fistula makes its way to the external skin. Now we have something called a supralevator fistula, wherein after passing through the internal sphincter, it ascends upwards, okay, and traverses through the puborectalis or levator ani, sparing the entire external fistula. External fistula is not at all involved in this particular type. Now we have got extrasphincteric, wherein both internal sphincter and external sphincter are spared. Here the source is much higher up. Okay, it spares both your external and internal sphincter, traverses through the levator ani or puborectalis, and makes its way through subcutaneous tissue, eventually ending up in the skin. Okay, so other classification can be simple and complex fistula. Simple fistulas are without extensions. Complex fistulas are with extensions, lateral extensions. It can be single external opening or multiple external opening. Multiple external opening are commonly seen in tuberculosis, ulcerative colitis, and Crohn's disease. Okay, coming to low level fistulas, its prevalence is 0.01% and it is more commonly seen in males. Okay, it often presents with seropurulent discharge, okay, along with skin irritation, and it can have one or more external opening with induration of surrounding skin. So this induration is very much important. So external skin, you see induration even at the internal opening in the anal canal. While performing digital rectal examination, you feel for that induration. Okay, this induration is a common feature in fistulas, particularly fistula in ano. One exception will be your tuberculosis. If it is a tubercular fistula, you will not find the typical induration which you see in other types of fistula. So this can be a neat exam question, wherein they'll ask you the fistula with no induration. The options can be your cryptoglandular disease, Crohn's disease, tubercular diseases, and let's say ulcerative colitis. Your option should be tubercular diseases. So often it may heal superficially, but the pus may collect underneath, forming an abscess, which again discharges through the same or new opening. So hence what we do is we remove more of the external opening so as to facilitate healing from below upwards. Okay. So rectal fossa on each side communicates with each other, okay, behind the anus, that is post-sphincteric space, causing horseshoe fistula. Okay. Now you have to remember this because there is something called as GOODSALL'S rule. I'll be explaining it in next slide. So you see why there is horseshoe type in one of the type. See the GOODSALL rule. So GOODSALL rule, basically what it says is, once the patient is placed in lithotomy position, okay, we assign the anal canal, we assign the position based on the dials in your clock. Okay, this will become 12 o'clock position. The anterior part will become 12 o'clock position. It is all assigned based on the dial of your clock. Okay, hence the same thing while describing hemorrhoids also, we assign 3 o'clock, 7 o'clock, and 11 o'clock position based on the dial of your clock. So anterior will be your 12 o'clock, posterior will be 6 o'clock, and then there is a imaginary line drawn between 3 o'clock and 9 o'clock. So anything above this line will be your anterior fistulas. Anything below this line will be your posterior fistulas. What Goodsall rule says is the anterior fistulas. Suppose if there is an external opening at 10 o'clock position here, the internal opening will be at 10 o'clock position only. Okay. Suppose here it is 1 o'clock position, the internal opening will be at 1 o'clock position. So this is called as direct type. It is called as direct extension. Okay. Whereas in the posterior part, what happens, no matter where the external opening is, the internal opening will be at 6 o'clock position, that is midline. Okay. The reason for this will be the connection between the two ischiocrectal fossa. There is a post sphincteric tract. So the most often this will be the tract for the fistula, hence the horseshoe shape is seen. Okay, so that is why I wanted you people to remember the previous slide. So no matter where the external opening is, and the internal opening will be at 6 o'clock position, and most often the posterior type will have multiple external openings. So that is also one of the point. So this is the basic gist of the Goodsall rule. This is very much important for your theory paper. It has been repeatedly asked as a short notes question. Okay, so the fistula with an external opening in relation to anterior half of the anus is of direct type. Fistula with external opening in relation to posterior half of the anus has a curved tract, maybe of horseshoe type, opens in the midline posteriorly and may present with multiple external opening, all connected to a single internal opening. So this is the Goodsall rule. Now the investigations. So basically you perform certain tests to rule out certain diseases. Chest X-ray ESR is done to rule out tuberculosis. Barium enema is done to rule out carcinoma. Okay. Colonoscopy is done to rule out ulcerative colitis in Crohn's. Okay. And there is something called as fistulogram. Nobody does that anymore. Wherein you inject radio opaque material into the fistula and take X-rays to see the path. Nobody is doing that anymore because we have got advanced modalities. MR fistulogram is the most ideal one, but that is expensive. Hence, we usually perform transrectal ultrasonography, TRUS, or endorectal ultrasonography. So this is done to assess the tract. Okay, this is the image showing fistulogram, wherein a dye is being injected into the fistula and X-rays are taken to see the tract. Now treatment, we have got fistulectomy, fistulotomy. There are various types of treatment for fistula. Fistulectomy means you only remove the fistulous tract. You will not remove anything else. The way you perform is after spinal anesthesia, general anesthesia, you pass a probe through external opening. Okay, so and you bring it out into the internal opening. Now this will be your guide. This will tell you the tract. What you have to do is you have to dissect all around the fistulous tract and go as close to the internal opening as possible, and then you end your dissection right then and there. You don't go beyond that. So this will be your fistulectomy. Ectomy means removal of fistulous tract. Okay. So post-operatively, patient should do sits bathing, antibiotics, analgesics should be given. Okay, fistulectomy for low-level fistula do not cause any rectal incontinence. Okay, so proper curating of the infected inner gland is very much essential. Otherwise, there will be recurrence. Now there is another type called fistulotomy. Otomy means open. Anything you leave open is called as otomy. Colostomy, ileostomy, otomy. Otomy means leaving it open. So fistulotomy, what we do, you don't dissect, rather you lay it open and let the uh, fistula heal or granulate from surface to surface, floor to surface. Okay, it is technically safer, easier, and it can be done on an outpatient basis. Now there is something called as gluing of fistulous tract. Okay, where fibrin glue is used, which is nothing but human plasma fibrinogen and thrombin. Okay, so this is injected into the fistulous tract, which hardens within few minutes. Okay, the success rate is hardly 70%, hence it is not advised anymore. Okay, there are newer techniques called as lift and waft. Lift means ligation of internal sphincteric fistulous tract. Waft means video assisted fistulous tract ligation. Okay, these are the newer techniques. Now, high level fistulas, here the upper opening is above the anal ring, that is anorectal ring. It is difficult to treat. Incontinence may follow after laying open of these fistulas. See, we discussed that higher up it is extra sphincteric. It doesn't involve either external sphincter or internal sphincter, but there is a high chance of you injuring external sphincter. Hence, incontinence is one of the possible complication of such surgeries. Okay, you that's what it's a part of. While treating, you might injure. That is when you can expect incontinence. Otherwise, these fistulas are most often extra sphincteric. It doesn't involve either internal sphincter or external sphincter. Okay, and the causes will be Crohn's disease, ulcerative colitis, trauma, carcinoma, and etc. Okay. So investigation will be same as the low level fistulas, except we take biopsies here. Okay. Here it is stage procedure. First thing you should do is ileostomy, divert the fecal matter. Okay. Then perform the definitive procedure. Okay. That is fistulectomy or fistulotomy, whichever, or the newer techniques such as waft can also be used. Okay. Later, the colostomy should be closed back. So this is a staged procedure if it is a high anal fistula. Now there is something called as Seton Technique, which you people should be aware of, wherein you use silk or linen ligatures to pass through the fistula. Okay, and you tie it. Okay, and what happens is due to the pressure, there will be ischemic necrosis of the muscle, and it starts cutting. Okay, this is a very lengthy procedure. Okay, it takes about 3 months. Okay, every week the patient has to come to get it tightened and tightened, as it is cutting through the multiple layers of muscle and mucosa. Okay, the trick here is it induces ischemic necrosis and thereby slowly cutting the fistulous tract. Okay, so this is about Seton technique. Certain technique, that's what it is, a long procedure up to 3 months it will take. Okay, it does not cause any incontinence. Okay, and it is done only for a intersphincteric fistulas, not done for a, suppose if it is transsphincteric, you cannot use this technique because we don't want external sphincter to be damaged. If that damages, then there will be incontinence for flatus and fistula, flatus and stools. So it is done only for intersphincteric type of fistulas. Okay. Thank you.